And now, a word from our sponsor.
It's time to step up, prep up.
Step up, prep up.
To help keep you free from the risk of HIV.
From the makers of Truvada, a new PrEP option, Descovy for PrEP, a once-daily prescription medicine that helps lower the chances of getting HIV through sex. It's not for everyone. Descovy for PrEP has not been studied in people assigned female at birth. Talk to your doctor to find out if it's right for you.
Step up for health and body.
Prep up for your one and only love, or many loves.
For kings, this queen, and you royals in between.
For my now.
Our now.
And my future.
Our future.
Step up, prep up.
Descovy is the newest way to prep. Descovy does not prevent other sexually transmitted infections, so it's important to use safer sex practices and get tested regularly. You must be HIV negative to take Descovy for PrEP, so you need to get tested for HIV immediately before and at least every 3 months while taking it. If you think you were exposed to HIV or have flu-like symptoms, tell your doctor right away. They may check to confirm you are still HIV negative. Serious side effects can occur, including kidney problems and kidney failure. Rare life-threatening side effects include a buildup of lactic acid and liver problems. The most common side effect was diarrhea. Tell your doctor about all the medicines and supplements you take, or if you have kidney or liver problems, including hepatitis. If you have hepatitis B, do not stop taking Descovy without talking to your doctor. Ask your doctor about your risk of HIV, and if Descovy for PrEP is right for you.
Words are loud, but actions are louder.
Step up,
Prep up.
With Descovy for PrEP.
Get help paying for Descovy for PrEP. Learn more at stepupprepup.com.
Good afternoon. My name is Bill Nichols. I'm the Vice President of Global Marketing for Sickle Cell Disease at Bluebird Bio, and I'm honored and privileged to be here with you all today. I am enjoying my time here in the warmth of Georgia, but incredibly disappointed that we couldn't all be together at Riverside Church. As a proud alumnus of Morehouse College, Dr. King has had the opportunity to be in the pulpit at Riverside, and I think it's just one of those opportunities that COVID has changed the way we work, but obviously what we're here to talk about throughout the day remains incredibly important. As I mentioned at the outset, I work for Bluebird Bio, and we are a gene therapy company based in Cambridge, Massachusetts. We have a research facility in Seattle, as well as a manufacturing facility in Durham, and have over 1,000 employees across the world. We are and continue to be committed to developing gene therapies for severe genetic diseases and cancers, with the goal that people facing these potentially fatal conditions with limited treatment options can live their lives fully. In the US, we're obviously working in 4 different areas, including sickle cell disease, which I have the honor and privilege to lead that work on the commercial side. But our gene therapy process works by genetically modifying the patient's own cells. We have extensive expertise in the design and manufacturing, as well as the vector delivery systems. And really what it is a gene therapy platform that has broad potential applications in a wide variety of places where there's significant unmet medical needs. And so at Bluebird, we really do believe that partnership is how we can change the way people think about sickle cell disease, and together we can improve that care. My work, obviously, I spend a lot of time trying to think through how do we become a part of the greater sickle cell ecosystem and the sickle cell community. I've had the honor and privilege of meeting a lot of fierce sickle cell warriors that bravely live their best lives while battling the disease. And I've also met a lot of healthcare providers in the 20 plus years I spent in biotech and pharma. Perhaps one of the fiercest and most humble I've ever met is Dr. Ahmar Zaidi. I met Dr. Zaidi a little more than a year and a half ago. First, we met probably close to 2 years ago on a telephone call. And it was a cold call where, I'd seen this guy tweeting, and he was tweeting, and I said, man, like this doctor gets it. And not because he gets it in the sense of he understands not just the science and understands how hard sickle cell warriors fight each and every day. But one of the things about Dr. Zaidi is I'm going to do things a little bit differently. We finally had the chance to meet in December of 2019, and he came into the room very quietly and very unassumingly and listened for a while and listened for a while. And then he jumped in. And one of the things that he said to me that sticks with me to this day is to sit around and talk to physicians all day about sickle cell disease or talk at patients every day about sickle cell disease really doesn't do it any justice. And so I want to be where the community is. And that community is the community at large and the full ecosystem across the healthcare system. And that includes patients, physicians, industry, payers, and the broader conversations around health disparities. And so Dr. Z, as he goes by for most of us, is a classically trained hematologist who continues to work tirelessly for individuals living with hemoglobinopathies, in particular sickle cell disease. He is a former postgraduate fellow of Children's Hospital of Michigan, one of the country's largest pediatric sickle cell centers. And still at Children's Hospital, Dr. Z continues to make timeless contributions and significant just work around research and patient-related outcomes, and really trying to think through, what can we all do? So when he's not caring for patients in the hospital, he's caring for them in the community, as well as he's quite the family man. And so he's someone that I am pleased to know as one of the good guys in my circle and in my network, but he's also one of the people that I know he will continue to speak for those who don't necessarily have a voice. And so with that, I'll turn it over to Dr. Z. Welcome.
Bill, thank you so much for that really kind introduction. I mean, I'm proud to say that I have partners in industry that are as committed as you are to the same patient population that we're trying to do good for. So what I want to do today is recognize, first of all, how important this Black Health Matters Summit, Winter Summit is. How important it is to have conversations around rare disease and how rare disease affects the Black community. And I want to spend some time talking about, if I have your permission, Bill, a story. Can we start with a story?
We always remember the story, so go for it.
All right, so let's do this. So several years ago, I took something called an implicit bias test, and the results shocked me. I found that I had an implicit bias, and my implicit bias favored white patients. But how exactly did that happen? My father, he was a Canadian Pakistani professor of political science, and he was a liberal socialist who believed strongly in the achievement of equity in the human condition. So we grew up having, dinner table conversations about race and religion with this really firm belief that people had more in common than not. My friends, of course, were white Canadians from down the street, but they were also the children of immigrant families from China and Iran, Somalia, Albania. We had discussions around race and culture, and they were mostly pleasant and usually really instructive. But in the end, it's the words that are never said that are the loudest, right? It's the subconscious that gets flooded by mainstream media and textbooks and subtle social cues. These are the things that creep in and settle in the depths of our mind. My implicit bias was real. And that was despite me being a minority. After discovering that, I started to wonder, how is my implicit bias affecting my patients? How am I, as a physician, personally contributing to racial health disparities? And as a sickle cell physician to mostly Black patients here in Detroit, that's something I couldn't allow to happen. I couldn't allow for my bias to be amplified through this power dynamic of the physician-patient relationship. I had to do something about this, right? So what I did was simple enough. I acknowledged it. I acknowledged that I had a bias, and then I worked to address it. And it was just in time because in the last several years, a new light has been shed on racial health disparities, of course, shining brightest in 2020 as COVID blitzed our country. We all braced for impact, especially hematologists, knowing what was going to happen. How is this pandemic going to affect patients with complicated disorders like sickle cell disease? How is our fractured healthcare system going to respond to an unseen and unknown enemy? And it became super clear early on that communities of color, particularly Black and Hispanic communities, were suffering, and they were suffering disproportionately. And it wasn't shocking to many of us that the death toll from COVID-19 was higher in the Black community. Because from the early medical abuse and exploitation of Black slaves to the modern day health deserts in urban Black America, the plot of this story was, according to a template, as unoriginal as it is heartless. And though the media engaged about why were Black patients overrepresented in COVID-19 mortality statistics, this wasn't news to us. It really wasn't news at all, because for sickle cell doctors, this was another day on the job. Decades of treating hematology's back of the bus disease really builds perseverance. You learn to find opportunity in hopelessness. And in this talk, I kind of want to discuss how we can continue to find hope while we take on the battle of bringing equity to treatment in sickle cell disease patients and reduce biases in ourselves. The simplicity in the mutation that causes sickle cell disease is contrasted by the psychosocial complexities of a disease that exists in this country as a direct result of the transatlantic slave trade. Sickle cell disease epitomizes a representative model of the extremes of racial health inequities that exist in this country. So let's start with another story. Let's go all the way back to the beginning. The first story of sickle cell disease and a sickle cell disease patient in this country is routinely told. And the protagonist of this story is a guy named Walterclemental. We've all heard this story. This is a classic story of Walter, who is really the first description of sickle cell disease in the Western literature. He was a well-to-do Grenadian dental student who comes to the United States to pursue advanced training. He's met by a really enthusiastic intern who does a whole bunch of tests and even does some extra tests, like looking at the patient's blood under the microscope. And that, of course, unlocked the crucial finding in this disease. But the contrast between Walter and the average sickle cell patient in the United States always has bothered me. What's the reason for the intense attention that Walter got? Was it because he was a fascinating medical puzzle, or was it because he was a foreign, well-off dental student? Was it because he was part of the medical fraternity? I'm not really sure. But something in that story always framed it for me as less an illustration of curiosity and ingenuity in action and more a mirror reflecting our own lack of effort as physicians. A lack of effort from us that exists even though millions of people with sickle cell disease have to dive deep into their souls to find strength with or without their physician's help just to get through the day. You see, Walter's not a typical sickle cell warrior. In fact, nothing about his story resonates with what we've come to accept agonizingly as the norm. And the truth is, if you keep digging into the literature, you find a report from 1846, and that gives you a better glimpse about what sickle cell actually looks like in this country. Dr. Robert Levy describes a runaway Black slave who escaped the plantation, was convicted, and then executed. In that report, it states that his body would be delivered to any surgeon who would demand for it to be examined. The slave is described as a man of irritable disposition who suffered from frequent fevers and pain. And in his autopsy, he's found to be missing a spleen and to have leg ulcers. And to anyone who sees sickle cell patients, this very likely then sounds like the first description of a sickle cell patient in the United States, a nameless runaway slave executed. And of course, this is much more congruent with what we've come to expect of sickle cell disease in this country, because we know there's no glory in sickle cell disease. Racism, bias, prejudice are intertwined as firmly with this disease as anemia and jaundice and pain. What can we expect, though, from a country where a medical apartheid has suppressed minority health to a point of no return? Let's fast forward from 1846 to 2020, where in a span of 8 minutes and 46 seconds, George Floyd told a police officer with a knee on his neck, "I can't breathe," 20 times before he ultimately lost his life. And it's not just George Floyd, right? It's Trayvon Martin, Eric Garner, it's Breonna Taylor, it's Philando Castile, it's Ahmaud Arbery, and so many others. It's our unfortunately reliable reminder that we really haven't come far on the front of racial equity in this country. So in 2020, as thousands of people took to the streets saying Black Lives Matter in a cry for justice and equity, all I could think about was my sickle cell patients. Because what happens to the Black community by police is happening to sickle cell patients in hospitals and clinics. It's the same fight, it's just happening in a different place. You see, the most frequent interaction between these patients and the healthcare system comes during a vaso-occlusive episode. In sickle cell disease, red blood cells, they change from these smooth, disc-shaped, life-giving units into these sharp, jagged daggers that pump through the body. They rip through organs and blood vessels, and the end result of this is a lack of oxygen delivery from blood vessels getting blocked. So when you take a moment to really contemplate this, sickle cell disease literally is just a different type of I can't breathe. The pain that sickle cell patients feel is unimaginable to us. While at its core, the physical pain appears insurmountable, it's really the mental and the psychological pain that really threatens the well-being of these patients. It's the pain of not being believed. That's what tears them down. In hospitals around the country, sickle cell patients in pain and at their lowest find themselves accused of trying to get high. So it's the pain of having to clean up and dress nicely while your body's killing you slowly from the inside. It's the pain of having to explain that labs and vital signs can't show pain. It's the pain of hearing hallway conversations between doctors and nurses about frequent flyers and sicklers who are angry and uncooperative. How'd we get to this? And beyond that interpersonal racism that our patients face, the healthcare system's been infiltrated by hidden bias and racism that's been lingering beneath the surface throughout the country, and now recently has come back into the light of day in mainstream media and cell phone videos that are being shown to us over and over again. You know, the healthcare delivery system for these patients is flawed. Hospital administrators, driven by billing and money and US news rankings, have pushed sickle cell disease to the back of the bus. Ancillary staff support to a program that cares for mostly Black and mostly poor patients will never be a priority at any hospital in this country. And this is an unembellished contrast to diseases that predominantly affect the white population, diseases like cystic fibrosis. In fact, our colleagues, Bear and Song, they say sickle cell disease shouldn't even be called a disease of pain. It should be called a neglected disease based on the World Health Organization's criteria. Because we can't ignore the racially and economically motivated factors that have allowed for apathy from researchers and industry in terms of treatment advances from 1904 to 2021. Those treatment advances have led to cystic fibrosis getting tenfold more funding, despite there being 70,000 less patients. You see, the writing has been on the wall for centuries. And this is borne out in a lack of treatment options in sickle cell disease. It's borne out in decreased access to care and a shamefully high mortality rate. So my plea to you today, to all of you, to anyone listening to this, is to recognize the moment we're in and to meet this moment. Consider what you might be able to change today in the lives of sickle cell disease patients and how you could address interpersonal racism with patients, colleagues, anybody in your life, really. And how you could address systemic racism amongst institutions and policymakers, and how you could use your platform to really change things. It's time to become comfortable having uncomfortable conversations, and to speak unequivocally about race and racism with anybody, particularly those in healthcare, particularly those in industry. Mandate that institutions address the lack of means to assist creating kinder and more compassionate environments for sickle cell patients. And above all, the most important thing, if you do nothing else today, is to recognize your own bias. That's the most consequential action that you could take today. How do you think about sickle cell disease patients? The bridge of trust between Black patients and the American healthcare system has been crumbling for centuries. And I urge you to critically reappraise the history of ethical violations made under the label of medical research and the unremitting bias and prejudice that's alive and well in modern day America against the Black community. This is the only road to bringing patients and doctors together on the same team. This is the only way to unite in a common fight against a disease that threatens to extinguish hope for so many. And Bill, that's all I have for you today.
Well, it's a lot, Dr. Z. One of the things that I think would be that you brought up is, you know, the conversations and how important the conversations are. And I think for many of us who grew up in Black families, it's not just exclusive to Black people, because the thing about sickle cell disease is it impacts many groups. But I think what's important is that we're having the conversation, because without the conversation, none of us can make the change. And you think about the stigma. We just saw a commercial before you and I started around HIV and PrEP. If we could have people within the Black community and the healthcare system have honest conversations about sickle cell disease, how much more progress could we really make? And so a bunch of questions have come in during your talk, and I'll start in order that they came in. So one of the things that you also talked about is, and I've heard you speak about it before, could you speak about the stereotype or the predisposed notion of many in the healthcare system that sickle cell patients are drug seekers or frequent flyers versus the actual data that we see in terms of how frequently sickle cell patients do actually seek, opioid medications unnecessarily?
Absolutely. So, we know that this country is in a opioid epidemic. We know that. There's no doubt about it, right? We know that there's opioid overuse. But we also know that in the same time that the deaths from opioid use have expanded 300 times, in that same time frame, the deaths in sickle cell disease patients from opioid overuse are basically zero. Opioid overuse is not killing sickle cell disease patients. Sickle cell disease is killing sickle cell disease patients. And it's always easy to blame the minority communities, right? The minority communities are a scapegoat for a lot of things. And it's so easy to say risk factor for opioid overuse disorder is being Black. But really, it's not race, it's racism, right? The risk factor here is racism. And that's a me problem, right? That's not a you problem as a patient. That's something that me as a healthcare provider, that's something I need to address within myself. So what this is going to take is a grassroots movement. What this is going to take is having this conversation with every medical trainee that we ever come across, right? What it's going to take is when I round on a patient with sickle cell disease with a medical student, we'll talk about sickle cell disease's biology, but we'll also talk about the racism that sickle cell disease patients deal with, right? Because that's part of their disease. So the narrative is driven at its core by prejudice and bias.
Absolutely, absolutely. A couple of questions here around sickle cell trait and the impact on and its impact on health. Maybe I could combine two questions. So if you could speak to the impact of sickle cell trait on the health of those with trait, and also maybe speak about the mutation and why it was originally seen in Africa, and the origins of sickle cell trait is not necessarily a bad thing in evolution.
Sure. Yeah, absolutely. So when I talk to my young warriors in clinic, because I'm a big believer, Bill, in empowering patients with knowledge, when we talk about sickle cell disease, we talk about it as a superpower, right? What we have to recognize about sickle cell disease is the creation of sickle cell disease comes in a moment in time where those who lived in areas where malaria was a problem were being devastated to the point of humans needing to develop a superpower to save themselves, to allow humanity to continue on. Something needed to change, and something did change. The change came, though, in the beta globin gene. It came in the way hemoglobin was being made. And we know the original sickle cell mutation comes about 5 times over the course of time. 4 times in sub-Saharan Africa, 1 time in the Arab Indian region. And when that mutation comes around, what happens is, let's say in a group of 1,000 people, 1 person is born with that sickle cell trait gene. That person with that sickle cell trait gene suddenly is living longer because his body's not being devastated by a specific type of malaria. It's given him a superpower to persevere in an environment that probably otherwise would have killed him. And now suddenly he's able to pass on that gene to more people because he's living longer. And it passes on to more people from there, and more people from there, and more people from there. Sickle cell trait is a badge of honor that allowed humanity to persist. And that's how we should think about it. Yes, when sickle cell trait combines with sickle cell trait, you get sickle cell disease. With great power comes great responsibility. And I think that framework, the way that we think about trait is sort of really causing, it's contributing to the stigma associated with the way we talk about sickle cell disease. Now, what does sickle cell trait do to a body? Well, we talked about the good. Let's talk about the bad. So we know that sickle cell trait in certain conditions, extreme exhaustion, extreme dehydration, high altitude, can cause issues, right? It can cause pain. It can cause clots. It can cause, things like this. It's also associated with a highly aggressive, rare, but highly aggressive cancer called renal medullary carcinoma that almost exclusively happens in patients with sickle cell trait. So there are some downsides, right? But the truth of the matter is that when you look at the Black community, 1 in 12 patients in the Black community of the United States have sickle cell trait. That's a huge number. There's hundreds of millions of people around the world with sickle cell trait. So we really need to change our narrative around sickle cell trait and really our understanding.
Absolutely. Could you maybe speak to um, the role of stem cell transplantation in the desire to eliminate sickle cell disease?
Yeah, certainly. So, you know, we often talk about, so let's back up just a little bit. I mean, one of the nice things, we talked a lot about the bad that's happening in 2021 and 2020, but you know, one thing to recognize is we are in a moment in time where there's innovation around sickle cell disease. Things are changing quickly. We have 4 FDA approved therapies. Cure is something that we're talking about regularly, which is just phenomenal, right? To be able to even have this conversation shows how far we've come. It's taken a long time, but we're here. We're in an area of innovation. We're in a time period where literally what happens in these 5 to 10 years is going to change how we tell the story about sickle cell disease 30 years from now, right? We're going to talk about 2020 and 2021. When we talk about cure, we talk about modifying the root cause of sickle cell disease, right? Changing the instructions on how hemoglobin is being made. And there's a couple ways to approach that. So the one that we talk about that's existed for quite some time has been bone marrow transplant, where you get the bone marrow from a matched sibling. Recently, people have been using parents as donors. And you basically replace the sickle cell patient's bone marrow with bone marrow that doesn't make sickle cell blood. There's a lot of downsides to that process. Some people don't have suitable donors. Some people have, you know, issues with the bone marrow being successful later on and needing immunosuppression and things like this. So recently we started talking about gene therapy and those individuals who may not want to deal with immunosuppression and the downsides of getting someone else's bone marrow in your body. We also look at this as a possibility for patients that have not had historically access to a good donor, right? Because in this scenario, in gene therapy, you can be your own donor. Now, we're really early in the phases of gene therapy. This is an intellectual thought that's being carried out slowly and going through the rigor of the scientific process. And we know that because of what the medical and research community has done to minority communities, the scientific rigor around these trials is immense. And every single detail is going to get, you know, looked at with a microscopic lens. So we're in the early phases of gene therapy, and you know, hopefully we get to a point where it becomes a reality for a big number of patients. But I'm at this moment just pleased that we have the spotlight of innovation shining on sickle cell disease.
Absolutely. As you know, I feel very passionately about it as well.
Yeah. Right.
Because you know, with newborn screening and you know a lot of questions around genetics and family and
Sure.
trying to understand, you know, do I have a loved one with sickle cell trait? And you know, maybe you could share how we've moved from optional newborn screening around sickle cell disease to it being part of a newborn panel. And if someone doesn't know for sure their trait status, how can they find out?
Yeah. So essentially, every child born in the United States at this point should undergo newborn screening that includes a panel for sickle cell disease. Okay. So we should have that information for individuals born in the United States. If you're not sure of your trait, you can just ask your doctor. Just ask your doctor to say it's a simple blood test. You could also reach out to your local sickle cell community-based organization who certainly can help find you a lab that can test for trait. Now, if there's questions around genetics, what we should talk about really quickly, Bill, is if you have 2 parents with sickle cell trait, the probability of having a child with sickle cell disease is 25% with every pregnancy. So you could have sickle cell trait parents, both mom and dad have sickle cell trait, and they could have children that don't have sickle cell disease, but they should know that there's a 25% chance of having sickle cell disease. The other thing to know is that sickle cell disease is not just sickle hemoglobin and sickle hemoglobin. It could be sickle hemoglobin with hemoglobin C trait. It could be sickle hemoglobin with beta thalassemia trait. So there's different combinations that could lead to sickle cell disease ultimately. It's a little bit convoluted, but I urge you, if you have questions about this, number one, find me on social media at Dr. Z Sickle Cell. Reach out to your community-based organization, and keep asking questions, because that's how we're gonna get to a point where we're comfortable with our knowledge around sickle cell disease as a community.
Absolutely. Absolutely. I think the conversation has to continue. With that in mind, what are some of the general best practices around treatment today, right? You talked a little bit about gene therapy being something for the future. You talked a little bit about uh, stem cell transplants and how rare, and bone marrow transplants, how rare they are today. What does typical treatment look like?
Yeah, so that's a good question. Typical treatment in most patients looks like, so there's a couple ways to approach this question, Bill. The first question is, what is the blueprint that doctors have? Okay, and what the blueprint that doctors have might not be the blueprint that patients want. Okay, and I think that's a really important distinction to make. The blueprint that doctors have looks like starting someone on hydroxyurea around 9 months of age with SS disease, and then watching them and screening them for things that they may be high risk for, like stroke, and instituting blood transfusions if they are high risk for stroke. Now, what we know is that as physicians, our guide should never be to dictate healthcare decisions. Our role as physicians should be to share data and guide patients in making their own decisions. What we have now is the ability to sit down with patients and say, let's talk about your options in sickle cell disease care. I have hydroxyurea, and I can combine hydroxyurea with other medications. But let's talk about these new medications. We have medications like Endari, like Oxbryta, like Adakveo, that help in different ways in the sickle cell disease patient's body. This is the time to sit down with your physician and talk about your options in therapy, and talk about what your blueprint looks like. Because every sickle cell disease patient has a different sickle cell disease story. So we can't treat every single sickle cell disease patient the same. That's really the key point that I want you to take away from this. Is we're in a position now where we have multiple tools. Let's use them.
Absolutely. A couple other questions have come in just around trait and making sure that people can understand if they have trait. What are some of the things that family members or the sickle or patients with trait themselves can advocate with their in their sports and their activities? I think the NCAA and the military, actually two of the larger bodies that do a lot of work around trait. Could you maybe share some of that information with us?
So one of the things that has been a point of contention has been the testing of trait, the exclusion of individuals with trait, almost because when you start excluding people on the basis of trait, you recognize that you're further oppressing this minority community. You're strengthening the cage of structural racism around them. American Society of Hematology has come out and said global testing for sickle cell trait in athletes should not happen. In fact, the measures you're going to take to protect individuals with trait should be applied to everybody. Mm-hmm. Everybody should have access to good hydration and rest, and not being treated poorly at the expense of their health. So the American Society of Hematology is clear on this, that testing for trait is not something that should be mandated, and I agree with that.
And so, how does trait reveal itself? If someone, obviously, we talked at the beginning about how oftentimes in the Black community there's not a lot of discussion around healthcare, and I can speak for myself. When I got married, actually here in Georgia, we had to take a blood test to make sure that my wife and I didn't, or fiance at the time, didn't have sickle cell trait. And so, how does it reveal itself for folks who aren't sure? To the blood, beyond the blood test, are there things that folks can look for that they might want to make sure they follow up?
Yeah. So recognizing that we need to wrap up soon, I'll quickly answer this. We certainly know that individuals with trait can present sometimes with pain, and often it happens in the setting of dehydration. Often it happens in the setting of stress that the body's put under. One of the things that's really important that I tell patients about is there is an association with developing kidney disease earlier when you have sickle cell trait. So if you are from the Black community, from a minority community, knowing that chronic kidney disease is a problem, that's something that you definitely want your doctor to be aware of so that they can stay on top of it and really make sure they've got an eye out for it.
Would you suggest early screening for renal cell carcinoma as well?
Yeah, I mean, I think it's reasonable to get like a urine analysis and renal function testing once a year in individuals who have sickle cell trait.
Great, great. This is a really timely question. You alluded to it, but just the impact of COVID-19 on sickle cell patients and their families, especially with vaccine and a lot of discussion around should we get a vaccine or should people not get a vaccine. Could you speak to that just a bit?
I got my vaccine and I will recommend it to every sickle cell patient. The reason for that, it comes from my research. So my research shows that the mortality rate in COVID-19 is about 11% if you have sickle cell disease. That's much higher than the general population, right? We are in a situation here where I can't predict what's going to happen to a body with sickle cell disease when it gets COVID. I don't know. I do know that individuals with chronic kidney disease who aren't on medication will have bad outcomes with COVID-19. Kids tend to do well, adults tend to do poorly. Protect yourself. Protect yourself. This is, I speak candidly. Anybody who's been listening to this, I would tell you, if there was a plot afoot here, if there was global domination, microchipping, I would tell you. I got it. My wife got it. My parents were going to get it. This is bigger than that. We really need to protect the minority communities from the devastation of COVID.
Yep. Without getting into too much direct medical advice, what are your thoughts on the benefits of an alkaline diet, medical marijuana? And could you also make sure you share with the audience your social media, because I know you're very active.
So I have a lot of thoughts about all of those things, but we are out of time. So what I'm going to tell you guys to do is follow me at Dr. Z Sickle Cell. Follow my podcast, Cheat Codes, a sickle cell podcast, so that we can talk about things like alkaline diet. You can hear the episodes on marijuana, and we can talk about holistic health and how that looks in sickle cell disease. But we can also talk about Western medicine and science. So please make sure you follow me. Bill, this has been a fantastic conversation.
Absolutely. I always enjoy my time with you and appreciate your honesty. And I just want to thank the organizers once again. And so Dr. Z Sickle Cell.
At Dr. Z Sickle Cell, right, Instagram and Twitter.
Absolutely. Absolutely. So thank you to Black Health Matters. And again, we want to make sure we continue this dialogue and many future dialogues. You get to hear a little bit more from Dr. Z later today. And we'd like to thank the organizers once again for their time and allow us to share the platform.
Thank you all.